Okay, so now we're going to start the case manager orientation. Um, the following information is relevant to the success of the role of the case manager here at Home Care Network. Please make sure that you do go through all of the information and listen to this entire presentation. Your DON is going to be according to the office that you work in, so make sure that you do make contact with the office, find out who your DON is, and make sure to get the contact information for the DON so that you will always be able to contact her. The office structure, the director of nursing is responsible for the day-to-day operations of your office. Each office has an office manager. The director of nursing manages and supervises all clinical staff. This includes office and field. And the office manager manages and supervises all the clerical staff. Each office is set up according to the needs of the individual office. You will be instructed on the layout of your office staff by a designated person. It is the responsibility of the case manager to learn each of these roles and have the knowledge of the significance of each employee has in the day-to-day operations of the office. The chain of command. It is very important to follow the chain of command to ensure the success of Home Care Network. Each agency has an assigned administrator that is responsible for each office within that agency. The executive administrator is the immediate supervisor of the agency administrators and is executive manager for clinical, training, education, and billing departments. The executive administrator oversees all agencies and is first in command on clinical decisions for Home Care Network. At any time that you have concerns, questions, and/or issues, you must contact your DON. If the DON is unable to assist you, it will be reported to the administrator. Allow the administrator time to address your concerns. The administrator will address your questions and concerns, and if the administrator does not have an immediate answer, your questions or concerns will be directed to the executive administrator. Home Care Network asks all our staff to be open to change at all times as we continue to make decisions to progress towards the continued success of the company. Welcome to the team. We are happy you are here. Okay, tasks and responsibilities of the case manager. The following are the responsibilities and tasks required of the case manager. QA OASIS, that is admissions, research, post-hospitals, and significant changes in condition. On these OASIS, we assist each one of the offices. So no matter which office you're directly working for, we all assist each other in making sure we get the OASIS reviewed and the 485s completed so that we will have them ready for billing. Case conference. We do have case conferences in a couple of the offices. It's just a weekly meeting. All of the staff comes together in order to review the patients that are coming up for recertification, and the case manager and director of nursing are responsible for running case conference. Performing visits as needed. It is our goal to have our case managers in the office as much as possible so we can keep the day-to-day flow going. But when nurses call in, or if we have a shortage of nurses and visits need to be performed, we will request the case manager to perform visits. Periodic ride-alongs and competency check-offs. We do ask the case manager to go out with the staff at different times for ride-alongs, whether it's for training or if it's for competency checkoffs. Missed visits, we have to make sure that we are notifying the physician, so it is the responsibility of the case manager to make sure that those missed visit reports are printed, and then our clerical staff then takes over, they fax them to the physician and get them attached to the chart. Transfers, anytime a patient is admitted to the hospital or any type of inpatient facility, the field staff or whoever finds out about that information is to report it to the case manager. It then becomes the case manager's responsibility to make sure that those transfer OASIS are completed and that the patient is added to the hospital log. HHRG scores, whenever you are reviewing the OASIS, we want to make sure that you are keeping up with the HHRG scores and making sure that the field staff are performing their documentation to the OASIS correctly. and also to review all communication notes within your caseload. For communication notes, you go through, you review them. Some of them need to be faxed to the physician. If you feel that it does need to be faxed to the physician, you would print it, fax it, note on the communication note the date you faxed it, initial it, and then also the name of the physician you faxed it to, and then make sure that you scan it to attach it to the chart to show that the physician has been notified. Some additional responsibilities that are required: on call, making sure supervisory visits are in compliance. So whenever you are reviewing the OASIS, you have to make sure that you are also reviewing the schedule. So if a patient has a home health aide in the home, you want to make sure that the RN is scheduled within every 14 days to supervise that home health aide. Also, we have to supervise the LVN at least once a cert period, so you want to make sure that that is done on the recertification visit. Coordination of care. As a case manager, you need to make sure that we are coordinating care between the physician, the office, and the field staff. Um, it is our responsibility as a home health agency, and it's also a regulation by CMS to show that we are coordinating care. So it's very important to make sure that we are documenting that. Alternating visits, review of home folders. Anytime that you do ride-alongs, or if you take a nurse or a home health aide out to perform a competency check-off, you want to make sure that you are reviewing the home folder, making sure the consent is there, the emergency care plan is there, and making sure that the staff are signing in as they are supposed to. And then also your paperwork is due the following day, business day, by 10 a.m. Tasks and responsibilities may change as we continue to grow, so please always make sure that you are open to change. Morning meetings are to be held every morning at 9 o'clock. I have requested for the staff to not go past 10, so we try to hold the meetings by 9. It allows the case manager to have a preview of the work that is needed. The office manager or the designee prints and makes copies of the reports for the meeting. We review insurance patients, order summary, certifications needed, orders due list, past due visits, alerts, the billing list, the pending list, and the hospital log. The Director of Nursing usually conducts the meeting and discusses every report listed in addition to information on the morning meeting report with input from all staff according to job duties. So instructions for each report are listed, and you want to make sure that you go through and know how to read those reports, but you would learn that directly from the meetings themselves. So during the meeting, you may get direction from the office manager or the director of nursing, giving some instruction on what needs to happen throughout the day, things that need to be done, taken care of. Also, this is a good time for you to bring up any information that the office in general needs to know or needs to be aware of. The referral process. If a referral is called into the office by a physician's office, the office nurse needs to document the following information: the patient's name, Medicare number, address, phone number, physician's name, and NPI number, contact person for the patient, special instructions, and pertinent information and other payer sources. Instruct the caller from the physician's office that someone from the intake department will contact them if further information is needed. The office nurse will write an assess and admit order, fill out the intake referral form, and send to intake department. Make sure to CC the intake director, agency administrator, and executive administrator. If the referral is called into the office by anyone else other than the physician's office, give them the intake department phone number, which is 877-270-2001, and direct them to contact the intake department with all the information. Referrals are generally received by the intake department. The process. a referral is phoned or faxed into the intake department, the intake director makes a decision as to accept or decline the referral. If accepted, the intake staff performs the following. They complete the referral intake form, they check the payer eligibility and benefits, they make sure that a physician's order has been received, and if not, they may contact the office in order for you to call the physician's office and try to get that order. Call patient to verify the information, and they inform them that the nurse will contact them to set up an appointment. They enter the patient information into Kinzer, and they send a heads up email to the office to let them know that they've received a new referral, and that an RN will need to be scheduled to perform that start of care. Then they will send a second heads up that has all of the patient information on it. They attach anything, whether it's orders, H&P, anything that the physician or the inpatient facility sends over to them, they send in that second email. That is the email that the office sends over to the RN with the report template on it. Once the admission is performed, the RN is supposed to complete the start of care admission report and send that back into the office. Reply all on the email. The next day, all appropriate offices check the status of the admission. If a patient is not admitted within 48 hours, the agency we have to make sure that we send a communication note with documentation to the physician to inform them why the patient wasn't admitted within 48 hours. And we need to also make sure that we notify the intake department. If a patient remains in an inpatient facility, the intake will keep up with that referral on their side until that information is sent over to the office. If the referral is a non-admit due to the patient refused or unable to locate from the agency level, after 48 hours, the intake staff will make sure to contact the marketer to assist in the location of the patient for more information. If a patient declines, intake staff performs the following. They list the patient on the referral not accepted report, and that is placed in the S drive. Once the scheduler has assigned the admission to the RN, on the office side, we need to make sure that we're keeping up with that email and also making sure that we're keeping in contact with that RN who's supposed to perform the start of care, and make sure that they understand that they need to send in the report in a timely manner. On that report, they are supposed to let us know all of the disciplines, the frequency of the disciplines that are needed, also any needs that the patient may have, if there's DME equipment or any type of medical supplies that need to be ordered. They're supposed to give full report on why that patient needs home health services and what is the purpose of us being in the home. On the discharges, all discharges must be approved by the DON before any discharge can be performed. The DON will discuss discharge with all the staff involved in the patient's care and make informed decision on discharging patients from service. The DON is to ensure that all services and needs of the patient have been met. If the patient on service for teaching and training, ensure that all teaching goals have been met. And during the morning meeting, discharges are discussed, and we have to make sure that a patient has been given their 5-day notice, and the RN has been assigned to perform the discharge visit. Avoid discharging from the desk if at all possible. And if a desk discharge is necessary, it is completed by the RN, the field RN, who was the last to visit the patient. On the clerical staff side, their immediate supervisor is the office manager. The clerical staff includes the office assistant, the clinical assistant, anyone in medical records, and the scheduler. Anytime there's a problem with the clerical staff, the problem should be brought to the office manager. On our software, we use Kinzer. You will be able to review and have a training on the Kinzer software also, so I won't go into detail on that at this time, but during your orientation you will have review of Kinzer. On the OASIS, it's the Outcome and Assessment Information System. It's a tool used to collect accurate and pertinent information regarding the patient, supportive assistance, and the patient's environment. And it's used by qualifying clinical staff only, which is the RN, the PT, OT, and ST. It must be complete and accurate when turned in. Case managers and other RNs in the office will review all OASIS before they are certified for approval. The OASIS is mapped out into components called M item numbers, and you will also later on go through OASIS training and you'll be able to get more details on the OASIS. On your HHRG and equations, your HHRG score determines your Medicare reimbursement for a 60-day episode according to the OASIS assessment. It is the responsibility of the assessing clinician to perform a complete assessment and document accurately to the patient's needs. Each discipline and frequency must reflect the assessment. Your HHRG score is made up of C, F, and S. The C score comes from your clinical M questions, the F comes from your functional M questions, and S is for service and is related to only one question, and that's therapy, your 2200 question on your OASIS. If you're referring one therapy discipline in the home, your anticipated number of visits will be 12. If you have 2 or more therapy disciplines in the home, your anticipated number of therapy visits will be 14. So if you have PT only going into the home, your M2200 should be answered 12. If you, for example, have PT, OT, and ST going into the home, your anticipated number of therapy visits is 14. ICD-9 coding, of course, the first 6 diagnoses have potential to contribute towards the C or the clinical part of your HHRG score. The RN performing the assessment decides the primary reason for home health. The diagnosis code should provide an updated and accurate picture of the patient's health. The RN lists each diagnosis related to receiving home care. M1024 is used when a V code is used, allowing collection of payment by inserting the diagnosis code that the C code is replacing. And your V code for therapy should only be used when therapy is the only discipline in the home. And then on your episode equations, you have 4 equations: equation 1, 2, 3, and 4. Your episode timing, it's either early or late. Early is the first or second episode. Late is the 3rd episode and any episodes to follow that. On your equation number 1, it's a early low, which means it's an early episode. It's either the first or the second. And they have low therapy utilization, 0 to 13 therapy visits that will be scheduled. On equation number 2, it's an early high, and the difference there is again the high because there are 14 or more therapy visits. On your equation number 3, it's late low. The late stands for 3rd episode or more, and your low therapy utilization visits is 0 to 13. And equation number 4 is late high. Same thing, your late episode or your timing is the 3rd episode or more, and your high therapy utilization is 14 or more visits. Okay, anytime that you are either performing an OASIS visit or if you're reviewing an OASIS visit, you want to make sure that you always run your OASIS check report and your PPS analysis report. We'll go over that in more detail whenever we review the OASIS training. But you want to make sure that you always do your OASIS check and your PPS analysis. Your OASIS check will go through and it will scan the OASIS. It'll let you know if diagnosis may be off or wrong or something was left blank. Your PPS analysis goes into more detail, and it compares things like your functional score on your 1800 questions, and then your supportive assistance questions later on down in your 2100 and your M2100 questions. So if you said the patient has needs assistance with ADLs or bathing, and then you go to 2100 and you say patient is completely independent with no assistance, then it will pull up an error to let you know you need to go back and review that. So make sure anytime you do an OASIS visit, whether you perform the visit itself or if you are reviewing, that you do those two things. Your 485 is your patient's plan of care. It is generated from the OASIS. So the 485 is not actually developed until or created until after the OASIS has been approved. So that way the 485 and the OASIS will match. And it's very important, especially on the billing side, for that information to match. But we will go over that in more detail as we get to the OASIS training. Task. Tasks are chosen by the RN whenever the OASIS is performed. In Kinzer, we have set up a drop down with templates according to diagnosis and disease processes. So all you have to do is you go through the different categories of pain, endocrine, respiratory, cardiac, the different assessments. As you go through those categories on the OASIS, you can choose the drop down and then choose the diagnosis as it is related for the interventions and also for the goals for that particular patient. And you want to make sure to always go in and make it individualized to that particular patient. And on the office side, the case managers or the clinical staff in the office reviews those OASISs and make sure that those tasks are relevant to the patient's care, and that's for all disciplines. So if PT, OT, ST, social worker, dietitian, home health aide, respiratory therapy, any of those other disciplines that we offer in the home are a part of what those patients' needs are, then on the office side, as a case manager, you need to make sure that there is an order in those disciplines and all the teachings that are necessary, even the skills, are on the 485. Every discipline in the home, like I said, should be listed on the plan of care. The teachings that are relevant to the current episode should be used. The RN should not choose a teaching for every single diagnosis because it will be impossible to do them all in just one 60-day period. So make sure whenever that you are choosing those drop downs that you are focusing on the primary diagnosis and any of the other diagnoses that are relevant for that patient. So if our primary reason in the home is wound care, and that is our primary diagnosis, like say for example a non-healing surgical wound, and we're doing daily wound care, we need to make sure that if that patient is having problems with their blood sugar, if they're not following their diet, that those are the things that you put in on your plan of care for the nurse to take care of on each visit. If the patient has a diagnosis of hypothyroidism and there's nothing going on with that, then you don't necessarily have to put that on the plan of care. Your plan of care should reflect the skills and the teachings that are needed for those diagnoses relevant to that patient and their problems at that time. You want to make sure that there's always a billable skill that is performed on every skilled nursing visit. The clerical staff does go through, and if there is a skill such as wound care that needs to be performed or an injection that needs to be given, if there's labs that need to be drawn, those particular things they will put on the yellow sticky, so it will be there whenever you come in. Whenever you pull up your visit, you will be able to see that there's more than just teaching that needs to be done in that particular visit. And you want to make sure that you always review your plan of care or your 485 before you go out to see a patient. On your M2250 on the OASIS itself, if you answer or check anything yes on that particular item, you have to make sure that it is used in the plan of care. So when you're on M2250 and you check yes, that yes means that you are including that particular thing on the patient's plan of care or 485. So if the patient is a diabetic, you want to always make sure that you check yes on your diabetic foot care. And then you have to make sure that in the body of the plan of care, you have chosen to teach on diabetic foot care. On your OASIS, again, you will see the drop down and you will be able to then pull up the one that best suits for that patient on that particular question. On how to review OASIS, we will go over that during the OASIS training, but you do review admissions, recertifications, significant change in conditions, transfers, post hospitals, and again, we will make sure to go over that in the OASIS training review. Notes are supposed to be turned in daily by 10 a.m. That is of the following business day. So that's not just for the field staff, but also for the office staff. So if you are called out to perform a visit, you want to make sure that your paperwork is in by 10 a.m. that following business day. A designated employee assigned by the office manager will contact staff if the paperwork is not received in a timely manner. An employee will report to the DON if that particular staff is uncooperative with the clerical staff. On the schedules, the scheduler reviews all patient schedules to ensure that everyone has a schedule every Monday. Then you want to make sure that you go through and review your schedule on Thursday, no later than Friday for that upcoming week. Because if there are any visits that need to be moved or visits where patients need to be seen on certain or particular days, you want to go through, make sure that's all taken care of and that those visits are moved to the proper day so the clerical staff will not be hounding you if your visit showed that it was supposed to be done on Monday and it's Thursday and the patient's not going to be seen until Friday. So if that visit actually gets moved to Friday, then the clerical staff will not hound for the paperwork. And so that's important for the case manager to know because you will have nurses that ask you questions about paperwork, but then also that same thing applies whenever you perform visits. Activities and information to ensure are on the schedule. This information is put on the yellow sticky note, usually by the clerical staff, but as a case manager, if you see information that needs to be added, you can do so. You will have access to document on the yellow sticky notes of the patient's chart. So the home health aide soup visits, you want to make sure that's done every 14 days, and that is actual and assigned task, so it doesn't have to go on the yellow sticky note, but you do want to ensure that it is scheduled. Your LVN soup visits, you want to make sure that the RN, whenever you review your research, that has been done if an LVN has been in the home in that particular CERT period. If there's been more than one LVN out at the home in that CERT period, all LVNs have to be supervised. Medication administration, so if there's any injections, IV therapy that may be performed. On your insurance patients, we have the skilled nurse evaluation that needs to be performed and that lets us know if the patient will continue to need home health services at the end of that particular certification period or if we will be discharging. And we also fill out a communication note on that and send that over to the physician. The 14-day wound evaluation, that make sure that that is assigned, and that includes with pictures, wound care, catheter care. You want to put on the yellow sticky note any request that the patient or the caregiver may have on that particular visit. If it's something that everyone needs to know that's a patient or caregiver request, then that goes on a different section on a purple sticky. And that's for anyone to be able to see that information. If you document on a yellow sticky, it is only seen by that particular visit. But if you document on a purple sticky, it allows everyone to see that information. You want to make sure that your research is scheduled within the last 5 days of the cert period. And then you can use your yellow sticky for any other pertinent information that you want the staff to be aware of. So if we've had a particular problem with, let's say, the billing department, the Medicare number may be wrong, or we're trying to find out the patient's social security number, or just any information that we may need to obtain from that particular patient or caregiver or family member, you can put on the yellow sticky for that nurse to obtain that information for you. Okay, complaints. All complaints are reported to the Director of Nursing or designated person upon the DON's absence as soon as possible. It does not matter how minor you think the complaint is, every complaint has to be reported to the Director of Nursing. Each complaint must be documented by the person receiving the complaint on the patient complaint form. The patient complaint form must be filled out completely and accurately. All complaints must be investigated upon receiving without delay, if at all possible. The DON or a designated person must follow protocol, take action, follow up, and document. The complaints must be completely resolved within 30 days of receipt, and each complaint must be investigated without prejudice. So no matter, again, how minute an employee may feel the complaint is, it does have to be investigated. Report all complaints to the administrator and executive administrator in a timely manner. Now, as a case manager and also the field staff, you report directly to the Director of Nursing, and the Director of Nursing will make sure that the administrator and executive administrator are made aware. All complaints are kept in a complaint notebook that is kept with the Director of Nursing. Any allegations of abuse, neglect, or exploitation has to be reported to the Director of Nursing as soon as possible, immediately, because that information has to be reported to the administrator immediately, because there is a process that has to be followed within 24 hours, which is called a self-report. Anytime abuse, neglect, or exploitation is reported, and that is abuse, neglect, or exploitation by agency and also family or caregivers. Employee concerns. Anytime that you have any concerns, you want to always make sure that you are reporting that to the Director of Nursing, or out of that Director of Nursing's absence, a designated person. We do want to make sure that here at Home Care Network, anytime you have any concerns, whether it be on the office side, on the clinical side, if you have an issue with maybe another coworker who is visiting the same patient you're visiting, or you have just general concerns with someone in the office, concerns about a family member or caregiver and how they are treating a patient or their relationship with a patient, you want to make sure any concerns that you have, that you bring that to the Director of Nursing's attention, and then the Director of Nursing will always make sure to get that information to the administrator. For the Medicare qualifiers, CMS has set up certain skills and tasks that need to be performed in order for a visit to be considered a billable visit. And so those qualifiers are listed below. You have to make sure that anytime that we are performing a visit in a patient's home, that it is considered a billable visit. So a skill has to be performed. So for example, if you go into a patient's home, the physician wants labs drawn. You cannot go into a patient's home and the only skill that you are performing is a venipuncture, because CMS does not see a venipuncture as being a billable visit alone. So you have to make sure you're also doing something in addition to that venipuncture. So for example, you may go into the home and do some teaching, and teaching and training is considered to be a billable skill or a Medicare qualifier. On your observation and assessment, you can only do observation and assessment for a maximum of 3 weeks. So you cannot be in a patient's home for observation and assessment for an entire cert period. So you may have observation and assessment of the primary diagnosis, but then you want to also include teaching and training. If we're administering any medications, um, if the patient has a feeding tube, if and we're doing actually performing a skill with that feeding tube, whether we're performing the feedings ourselves, if we're teaching a caregiver or a patient how to perform the tube feedings, your trachs and trach care, whether we're performing or we're teaching on the catheters, whether we're same thing, if we're performing the catheter changes or we're instructing or teaching the patient or caregiver. Wound care is considered a skill. If we are going into the home for wound care, our number one goal is to make sure that we are able to teach a willing and able caregiver or the patient themselves if they are able to reach the wound. If for any reason the patient is not able to reach the wound and can't perform the wound care, or they don't have a willing and able caregiver, then we perform the wound care as we go in and perform our visits. Ostomy care, same thing, and then heat treatments, medical gases, and rehabilitation nursing. Those last three are things that we don't perform ourselves, but they are considered Medicare qualifiers. For management and evaluation, we will just take a minute to just go over this, but at the present time, Home Care Network, we are not accepting or doing any patients for management and evaluation. RNs are the only discipline as far as nursing that can go in and perform a management and evaluation visit. This is a patient that is stable enough to where they don't need observation and assessment, but there continues to be a need for the nurse to oversee an unskilled caregiver to prevent exacerbations and rehospitalizations. There's a lot of strict guidelines to management and evaluation, and so we try to shy away from it, and we're not performing that at this time. But when a patient is on management and evaluation, there can be no other skill service in the home. So a patient can't be on management and evaluation and have therapy or a social worker. The only other discipline that can be in the home is a home health aide. And the goal of M&E is to prevent exacerbations and rehospitalizations, to minimize complications, and to monitor and evaluate underlying conditions. For chart audits, the case manager and the director of nursing are responsible to make sure that 5 chart audits are performed each month, each office. And on those chart audits, it's not the responsibility of the case manager and the director of nursing to perform the chart audits. It is just their responsibility to make sure that they are getting done. You want different disciplines to perform those chart audits, so you want to recruit your therapists, your RNs, your LVNs in the field to assist with those chart audits. You just need to make sure to notify them in advance so you can get 5 per month. Now, discharge chart audits need to be performed also, and the case manager and the director of nursing could assist with performing some discharge audits. Especially, we need to make sure that the 5-day discharge notification and the Medicare non-coverage forms are being completed, and the patient and physician are being notified of the discharge in a timely manner. And for that, the director of nursing, case manager, or designee would make sure to use the discharge audit tool. All of the chart audit information has to be tallied on the chart audit summary and completed with percentages. And then that chart audit summary is turned in with the monthly monitors. The director of nursing has to make sure that the QA department receives all reports by the 3rd of each month. For case conference, the patients are listed on the case conference report, and it is emailed to all of the staff by the office manager the week prior to the case conference meeting. It depends on which office that you are assigned to or which office that you work from on the date and the time of your case conference meeting. So you would find that out from your director of nursing. But each discipline that visits the patient in their home should attend case conference. Each discipline should give report. So that way the RN who's going to be completing the 486 will have the correct information to complete that 60-day summary so we can get that off to the physician whenever the RN performs the recertification visit. On the teaching, teaching should be relevant to the patient's needs. Each nurse should use nursing judgment and knowledge to choose relevant teaching. Also, teaching is included in the patient's plan of care whenever the RN performs the OASIS. And the following should be taught every start of care, resumption of care, and recert by the registered nurse whenever that particular visit is performed: the emergency care plan, emergency preparedness, and after hours on call. And that information should be documented on the OASIS each time. And actually on Kinzer, if you choose the drop down, you can choose the recert, admission, resumption of care, assessment for the narrative, and that information is included there. So you don't have to try to remember to type that out each time. Okay, on the billing coordinator for each individual office sends out a billing list. And the office is responsible for making sure that that billing list is getting completed and the billing goal for each day is met. That responsibility falls on everyone in the office, including the case manager, director of nursing, and office manager. So as the case manager, you go through, you review the billing list, any OASIS that need to be reviewed, 485s, any skilled nurse visits, home health aid notes that need to be completed. You would go through and review those, and then once the billing goal is met, then we are dismissed for the day. For the intake department, our intake department handles all referrals, and we've already gone over the referral process itself. Intake is the ones who take after hours call. So anytime that you are on call or any of the staff are on call, our intake department are the ones that receives those after hours calls. And then if you are the particular nurse that's on call, then they will contact you to let you know if a patient, physician's office, or anything patient related, they will make sure that that information gets to you, and they take care of any referrals or anything that are called in after hours. On agency forms, you want to make sure that we're only using agency approved forms. Most of the forms now we do have on the computer, and you are able to go under your communication notes and pull down a template to complete those forms. Any forms that actually require a patient's signature, we have to make sure that is taken care of in the patient's home. The nurses will then take a picture of that form, email it to the office, and then we attach a copy of that picture to the patient's chart. On your non-admissions, a patient will not be admitted to home health services. The DON has to make sure that a communication note has been written and all the information related to the reason for that non-admission is taken care of. On the case manager side, because you do go through and review communication notes every day and all throughout the day, making sure that those communication notes are sent to the physician, you have to ensure that anytime a patient has not been admitted, that we are getting that communication note to that physician in a timely manner to report why not. Time off requests. Requests for time off are first come, first serve, and they are all approved by your director of nursing. You go into the HR system and put in that request, and then your supervising nurse, which is your director of nursing, will take care of that for you and let you know whether or not it's been approved. On the skilled nurse in services, we are starting to conduct webinars because it is more convenient for the staff to come in to be able to get on their laptops or tablets or phones or whatever technical device that they can in order to be able to just get in and listen to the webinars versus trying to come up with one time for everyone to come into the office all at the same time. So we do make the webinars convenient by having 2 or more over a couple of days span to give everybody a chance to be able to log in and listen to the information that is needed. So anytime that you receive an invitation, make sure that you do register for those, because anytime you receive an invitation, that's letting you know that that particular webinar is mandatory and necessary for you to listen in on. Most of those webinars are hosted by the corporate educator. It could also be an administrator, your director of nursing, or even individuals from our QA team. In addition to mandated in-services, your DON or even corporate educator or administrator may have some specific problems that are going on in your particular office that need to be addressed. And so you may receive an invitation for a webinar with them just letting you know that there is some information that they need to go over with everyone. And then those reports on who actually attended the webinars are kept in the Skilled Nurse In-Service Notebook. And you will have the opportunity, for any reason that you weren't able to listen in on the webinar, to obtain the information that you need from the office. For the home health aid in-services, there are 12 mandatory subjects that have to be covered in the year. We will have those on our website, so it will be convenient and easy for the home health aides to just log on and get those in-services taken care of as needed. Also, just a reminder that now home health aides are required to do their continuing education hours also. So make sure for the home health aides that they are obtaining the continuing education hours needed in order for them to continue with their certification. For on-call, every nurse that we have that works for a home care network is a part of the on-call rotation, and the frequency of that rotation depends on the number of nurses that work for your particular office. So if you have 5 RNs in the field and you are a case manager, then you may be put into that rotation and end up with call every 6 weeks. It depends on how many nurses that you have in the field. Your director of nursing should try to make that on-call list out at least 2 months in advance, but of course she would have to change it according to the staff at the time if there's any staff changes. Call begins Friday at 5 p.m. and ends the following Friday at 8 a.m. So for that 1 week span, you will receive any phone calls while the office is closed. Again, we've already reviewed our intake department is the initial receiver of the call, and if it is something involving the clinical side, then they will contact you in order for you to be able to follow up with the patient, caregiver, physician, or whoever it is. We do always have an RN and an LVN on call together. The LVN is the one that will perform the regular skilled nursing visits to free up the RN for the OASIS visits that may possibly come up. So if we have daily insulin patients, if we have daily wound care patients, patients that any regular visits just need to be performed. If they have wound care that's 3 times a week and it falls on Tuesday, Thursday, Saturday, then that particular visit will go to the LVN. If you have any further questions about on-call, make sure that you always go to your director of nursing. On your policy and procedure, that manual is kept in the director of nurse's office with availability to staff whenever you may need to review it. Make sure that you are familiar with the policies and procedures and common practices adhered to by HCN. Our policy and procedure manual is kept up on a monthly basis through Healthcare Consult Link, or HCCL. Anytime we receive new policies or if there's any updates to any current policies, then we will make sure to get that information out to you. And then once we know that you've received that information, we have to keep record that all staff has been updated with any changes. Nursing procedures, that manual is also kept in the Director of Nurses office. We want to make sure that any particular clinical procedure that may need to be performed, if you're not familiar, if it's something you haven't done in a while, then you have that manual to refer to. And if for any reason you don't feel comfortable with performing a particular skill, you want to make sure that you do make your Director of Nursing aware of it, so we can have either the case manager or the Director of Nursing, an administrator, another RN, or a particular nurse to go out and assist with allowing you to become comfortable with that particular clinical procedure. To go over insurance patients, we have some patients that are insurance that their certification periods are 30 days versus 60 days. On those particular patients, you will be made aware of that from the beginning. We have a list from our insurance department on how to handle those patients. We do a 14-day skilled nurse evaluation going in on those insurance patients because we only get a certain number of authorized visits for each discipline from the insurance company, and sometimes it can take them a week or more to get back to us on any authorization. So we need to know at least 2 weeks in advance if that patient will need to continue with home health services, what disciplines they continue to need, how many visits they need on that particular with that particular discipline, and then we get that sent over to our insurance department who will make those requests. So we ask that you stay up on those insurance patients and keeping us updated with them, so we're not waiting until the last day of their certification period and requesting additional insurance visits, because then what happens is that patient is being seen and we're not receiving any reimbursement, which if you look on the business side, that's not good because there's not money coming in order to pay the staff. And then also, you don't want to be out visiting patients while you do not have authorization from the insurance company. So we want to make sure that we are obtaining those at least a couple of weeks in advance. Also, let me point out, if you admit a Medicaid patient, that Medicaid plan of care form has to go to Medicaid within 24 hours of admission in order for them to approve of visits, because Medicaid will just give you authorization for the skilled nurse to go out and perform an assessment, and then you have to report back to them that nurse's assessment and what we're requesting. Then they go from that assessment whether or not they will approve visits or not. For OSHA, Stericycle is the company that we use to keep in compliance with OSHA. Stericycle has scheduled pickup times for each office for disposal of biohazards. There are mandatory in-services through Stericycle that we must conduct, and then there's a mandatory annual in-service that they come in every year, and that's when they also do our office inspection. Please make sure that whenever your Director of Nursing makes you aware that it is time for that annual mandatory meeting, that you do attend. On wound protocol, all wounds must be measured on a weekly basis. We perform a wound evaluation every 14 days with pictures. You want to make sure that pictures are taken on the initial finding of the wound, anytime we do the 14-day wound eval, and also anytime a patient is admitted to an inpatient facility and they're coming out of the facility, you want to make sure that we're getting a picture of that, what that wound looks like before we start home health services up again. We want to make sure on that 14-day wound eval that we are documenting on a communication note the progress or the decline of the wound. That particular communication note, you just choose the 14-day wound eval template, then the case manager, it is your responsibility to get that sent off to the physician in a timely manner. For our finance department, they pretty much take care of the cell phones that are maintained by our field staff. They also take care of any other type of devices, whether it's a laptop, if you have an iPad, any medical supplies that has to go through the finance department. We do have a supply budget, but anytime you need supplies, you just email the supplies um, email address, and that will come to those particular offices. That email will come to those particular people in the offices who will order those medical supplies. On the dress code, anytime as a case manager that you know you're going to have to go out into the field, you are allowed to wear scrubs and comfortable shoes as though you are the field staff because you are going out to visit patients. But if you are not visiting a patient or you know that there's not a chance that you will have to visit a patient, then you are required to wear business attire to the office. And then we also do casual Fridays where you can wear your HCN shirt and jeans. Anytime that you're wearing business attire, you need to make sure that your shoes do have a heel. An open toe is fine at any time. Make sure that you do wear your name badge, and at any time, whether in the field or the office, you have to make sure that any tattoos or body piercings are not visible. For the PAC committee, that's the Professional Advisory Committee. It consists of a representative of each discipline and a community liaison. The committee meets annually with the medical director and reviews new and changed policies, the agency's report card, and the annual agency evaluation. It's conducted by the administrator or the executive administrator, and usually also the marketer for that particular areas will also attend the meetings. If you are asked to be on the PAC committee, then you will be informed when that annual meeting is to happen. On the peer review committee, it consists of representatives for the LVN and the RN. This committee, if you are required or asked to be on the committee, it is confidential. Any information that is shared, any testimony that is given during a judgment, you are not to repeat that information or share that information with anyone outside of that meeting. If an LVN is put up for review, then all of the LVN members of the committee will take part in the review, and the same for the RN. Only RNs can judge RNs, and only LVNs can judge LVNs. All DONs are members of the committee, but cannot participate in a review of their own staff. So if you are chosen to be on the peer review committee, just remember you do sign a confidentiality form, and then if you have any further questions, you can review the peer review committee notebook at each office. On STEER, we complete or make sure that the family members complete the STEER information that is in the admission pack. That is for the EPC 1 patients. That's your Emergency Preparedness Code 1 patients. Those are the patients that in case of an emergency or some type of disaster, that those patients need to be reached first and before any other patient. So when that STEER information is completed, we get that faxed off, and then that patient is then registered in their area. So if there is an emergency and that patient needs to be evacuated, the area emergency committee will make sure that that patient is evacuated, and they will assist the patient. On the field orientation, Every single nurse that comes in and begins new at Home Care Network must have a ride along with an experienced nurse. The majority of the time, we do ask another RN, another LVN in the field to allow that nurse to ride along for a day or two or however long that particular nurse needs. It depends on their experience in home health as to how long they will do the ride along. But the skills checkoff has to be performed by an RN. So whether it's a new LVN or a home health aide, the RN has to be the one to do the competency checkoffs in the field. So as a case manager, you may be asked to perform those type of visits as needed. Um, and then you want to make sure that you're always coordinating with the corporate educator. On the office procedures, all of HCN office procedures should be followed at all times. Our common practices, our policies and procedures. No procedure or process should be changed without the approval of the executive administrator. So please make sure that anything that you are taught in your orientation series that you listen to online, or different things that you are taught by the corporate educator or your administrator or your case manager, your director of nursing. If anyone questions anything that you've been trained on, make sure that you go to your corporate educator and ask before you change any type of way that you perform a process or a procedure, in order to make sure that you are following HCN company policy. That is the end of the case manager orientation. If you have any questions, please make sure that you do contact the corporate educator, Latanya Williams, at lwilliams@homecarenetwork.com, or if you call the main number 972-270-2000, they will connect you to whichever office that she's working in. Again, thank you for your attendance and welcome to HCN.